All right, so we're going to transition to our hospital presentations. So we've got 4 presentations and they'll each be about 15 minutes. We'll have a brief time for a question and answer, and hopefully we can fit them all in. The first one will be presented by Dr. Anike Nodoko, who's one of our neonatology fellows here on this campus, and she will be sharing the work that Children's Hospital Colorado, both the Anschutz campus as well as down in the Springs, are doing related to safe infant sleep.
Thank you, Dr. Wong. Hello, everyone. It's a pleasure to be here. And we'll just go ahead and get started. And so today we'll be talking about our Sleep Well initiative, which is the Safe Sleep Initiative here at Children's Colorado Anschutz campus and Colorado Springs. I have no disclosures. And so before we delve into the specifics of the program, just wanted to talk about why this Safe Sleep Initiative is necessary. So sudden unexpected infant death, also known as SUID, is sudden and unexpected death in an infant less than 1 year of age. This categorizes all deaths prior to investigation and includes those from known and unknown causes. For example, sudden infant death syndrome, also known as SIDS, suffocation and strangulation in bed, sleep-related deaths, and so on. An important distinction to make is that the difference between SUID and SIDS, which is sometimes confused for one another, is that SIDS is death that cannot be ruled out, cannot be explained after an investigation. And so SUID is a leading cause of infant mortality, and it affects about 3,600 infants annually. In the United States, about 10% of infants are born prematurely, and studies show that preterm infants are 2 to 3 times more likely to die from SUID when compared to their term counterparts. And so this is why this is a very important topic for us. And so here's a study by Malloy and others that was published in the 2013 Journal of Perinatology. And this looks specifically at post-neonatal out-of-hospital death by gestational age. And so patients were stratified by gestational age, and all preterm infant groups were individually compared to their term counterparts. And here we see that preterm infants have an increased odds of death from SIDS, other sudden deaths, and suffocation when we compare them to their term counterparts. And so during the initial NICU hospitalization, typically the need for acute therapeutic care is often at odds with safe sleep practices. So I think we're all familiar with the NICU environment. We have a new preterm infant that's admitted, requiring mechanical ventilation and a host of other care that often precludes being able to safely sleep, to incorporate safe sleep practices, including their developmental stage. And then we get to a point where we are convalescing and we're in that feeder grower stage. And we still continue to focus on those other needs, such as, nutrition, weaning of respiratory support, and so on. And then typically what happens is an infant will often surprise us and eat much faster than we thought they were going to. And then we realize, oh, you're probably going to be discharged in the next 2 days, and we start working on discharge prep. And at that time, then we start discussing with parents about what safe sleep looks like. But of course, because we've been in the hospital, we've had 24/7 care, and we've also been on 24/7 cardiopulmonary monitoring. That's not something that we've necessarily paid attention to. And now parents are expected to completely change the practices around safe sleep, and that can be overwhelming. And so because of this, and because of the increased risk of SUID for preterm infants, the AAP has recommended intentional modeling of safe sleep positioning and environmental, and making sure that the environment also is in accordance with those safe sleep practices once medical stability is reached. And so the next step was looking at, first of all, what does our safe sleep practices both in the NICU and at home look like? And so through Define Colorado, which you're all familiar with, we were able to get some initial data on what that looks like. And this was done by surveying parents in the NICU, that parents of patients that were admitted to the NICU. And so this is data from before the collaborative was formed. About 112 patients were or patient families were enrolled. About 79 of them completed their survey at enrollment, and about 33 completed the survey prior to discharge, and 26 completed the survey, post-discharge at home. And so the questions specifically looked at safe sleep behaviors. So first here, the graph on the left looks at items in the sleep area. And the darker green columns show us the items in the sleep area at enrollment, and then the lighter green columns then show us pre-discharge items in the sleep area. And so here we see that at enrollment, there is a preponderance of items in the sleep area, including but not limited to pacifiers, suction bulbs, birth clots, and so on, and blankets. We do see some improvement, at least in the responses from parents about items in the safe sleep area prior to discharge, but of course it's still pretty significant. Here, the graph on the right then looks specifically at infant sleep positioning at enrollment, which is shown by the yellow bar, and then the pre-discharge shown by the lighter orange, and then the burnt orange at home. And so here we see that, and just of note, this is just all observations of safe sleep position. So several, each family could select more than one choice. And so we see here that at enrollment, typically there was an increased adherence to sleeping on the back, and at home, those numbers decline over time. Sleeping on the stomach, also we see that there's a lot of patients sleeping on their stomach, and on their side as well, a little bit less. And while again, there is some here we see that less of these patients are sleeping on their back when they get home. And so when looking at post-discharge sleep behaviors at home, we see that about 93% of parents note sleeping in a crib, sleeping in a sleep sack. And then there are also some parents that note that there are some unsafe sleep behaviors, such as sleeping in a car seat, and having things like blankets and pillows in the crib. And then this pie chart also shows the percentage of infants that are sleeping alone at home. About 66% of them sleep alone all the time, always. And then from there on out, we see about 23% sleep often alone, and so on. And so I think what this data shows is that, we have some work to do, both during the hospital stay and also at home. And so Sleep Well is a multidisciplinary, multi-pronged initiative whose goal is to increase the use of safe sleep practices amongst medically complex high-risk infants who are discharged from the Children's Hospital NICUs, both at the Anschutz and Colorado Springs Medical Campus. And the goal is to do this through modeling, education, and partnering with families. And our aims are to increase safe sleep practices within the NICU by 50% within a year, and also increase the use of safe sleep practices at home upon discharge by 50% as well. And so how do we tackle this big topic? And there are several arenas that we're working on. First, looking at our NICU policy and making sure that they're up to date and aligned with AAP recommendations. Making sure that every staff within our NICU is well aware of what the recommendations are and well educated so that we can continue to put it into practice on a daily basis. We also looked at instilling a new practice of making sure that every infant has an electronic medical record order that specifies their sleep position, and with the goal of revisiting that on a frequent basis until we get to safe sleep practices. Another aspect of this is getting input from staff and families through qualitative interviews, just to make sure that we have a well-rounded approach to the implementations that are being made in the NICU. And then lastly, another important part of this is making sure that family-facing materials, educational materials, are up to date and also reflect our medically complex patient population. And so here is the first step was developing a safe sleep readiness and transition algorithm. With the goal of having a daily assessment by the bedside RN and also the team during rounding. Looking first at, is the patient at a developmentally appropriate age? And then looking at medical stability from a respiratory standpoint, feeding standpoint, and any other immediate needs. We also incorporated the evaluation by the developmental team to make in case there are any developmental concerns that would preclude safe sleep. And then based on all of this evaluation, we would either say that the patient needs to continue therapeutic positioning, they're ready for safe sleep, or they can have some safe sleep with some modifications and with a plan to reevaluate at a later date. And so the patient's sleep position would then be reflected on their crib for everyone to see, both, including the medical staff, but also parents, so that they know exactly what each position specifies. And so with the infant therapeutic position, it just explains what that means. And also saying that this is something that's happening in the NICU and not recommended at home, and that the patient will be transitioned at a later date to a safe sleep position. Oh, sorry. Okay, and then when a patient is ready for safe sleep, then it would specify exactly what that means. So back to sleep, making sure to have a firm mattress or in a crib or a bassinet, no sleeping in a car seat, swings, or positioning devices, and no unsafe items in the sleep area. Another aspect that we discussed earlier was the EPIC order, which again looks at the gestational age. And then of course, once a patient meets that age, then we go ahead and select the safe sleep position based on the previous assessment. And this is so that everyone that's taking care of this patient is aware of what is happening with the patient. And then we talked again about developmental of educational materials for parents. And often that the educational material around safe sleep that we see is often with a well-termed infant who has, most of the time, does not have any medical comorbidities. And so we will be working on developing those materials, making sure that they're inclusive and also represent our patient population. And so that our families are able to connect with what they're viewing, and also making sure that it's intriguing and not something that people just watch and just it kind of leaves their head as soon as they're done. And then we talked about an important part of this process is partnering with families. And so such as with Define, Love for Lily. And the goal is just to make sure that families are heard because we know that when families are involved in the care that we're giving, outcomes improve. And there's also a better chance of adhering to these practices at home because we've taken everything into consideration. And so These are the members of the Sleep Well team, which is led by Dr. Wong. And here you can see that we have a representative from all aspects of care within the NICU. And this is again to make sure that we have buy-in from everyone. We make sure that no concerns or questions are left unaddressed, and that we are able to tackle them together as a team. And this initiative has been funded by the Institute of Healthcare Institute for Healthcare Quality, Safety, and Efficiency. And so we are in the developmental stages with plan to begin implementation in the next couple of months. And then we will see what our data looks like once those changes are put into place, and hopefully they'll be for the better. Thank you.
Thanks so much, Anikin. And I do want to add that while I'm listed as the principal investigator for the grant, there are so much more leadership like coming from the nursing side for this effort. And I do want to recognize Jennifer Steff and Erica Lopez, who really have been convening these meetings and leading the charge. All right, questions for Anikin?
Thank you so much. I'm curious, with staffing shortages as they are, a lot of times the swing positioning devices, they're used also to help like soothe the baby.
Mm-hmm.
Is there any consideration? I mean, I should know this probably, but is there consideration for those pieces, even if we're at that 34-week or above 32 and all of the qualifiers for kind of the real life aspect of what's going on right now?
Yeah, there's definitely consideration for that. And our hope is, using it for soothing and also just to have the patient out of bed, I think is appropriate, but making sure that once a patient falls asleep, that we are really adhering to that. And just to continue to model, because I do agree with you. I think, being at the bedside, things are often busy in our unit. Sometimes it's difficult to put those things into practice, but our goal is just to model for parents. So hopefully they can see what we've done in the NICU and continue to do that at home, despite the real life and real world challenges. So, using them and making sure that once we notice that a patient has fallen asleep, it's time to then transition to the crib. Yeah.
All right. Thank you, Anikin.